Ritika, should I start?
Yes, ma'am. We can start.
Good evening, everyone. It is my absolute honor to welcome you all to the Indian Thyroid Society webinar, the Thyroid Clinics, taking place once a month. So we are gathered here today to discuss the groundbreaking insights in thyroid disorders and their management. So before we start, a short video of the Indian Thyroid Society will be played by the tech team. Thank you for that. So today we are here with some of the esteemed experts in endocrinology and endocrine surgery. So on behalf of the Indian Thyroid Society, I extend my warmest greetings to all of our distinguished speakers, panelists, and also participants who have joined us from across the country and beyond as well. Before I start, I would like to thank Dr. Krishna Sheshadri sir, who is the president of ITS, Dr. Arun Menon sir, the secretary, and Dr. Mini ma'am, treasurer, whose contributions are definitely immense in conducting this program. A special thanks to Dr. Pramila Kalra ma'am and Dr. Roma Pradhan madam as well, who have, and also the thyroid clinics teams for coordinating this enlightening session. So another short announcement before we proceed. Can we go ahead with the next slide? So those who are interested to submit their research in our flagship journal, that is the Thyroid Research and Practice, can do so by scanning the QR code. And those who are interested, in fact, to become a reviewer for the Thyroid Research and Practice can again do so by scanning the QR code displayed here, which will help you sign up as a reviewer. So moving on, tonight, we are privileged to have an outstanding panel of speakers and moderators, including Dr. Arpandev Bhattacharya, sir, who is the consultant in the Department of Diabetes and Endocrinology, and also the Professor of Endocrinology at JJMC Davangere, Karnataka. Dr. Abhilash Nair, sir, who is the Associate Professor of the Department of Endocrinology at Government Medical College, Thiruvananthapuram. Dr. Malika Madam, who is the Consultant Breast and Endocrine Surgeon at Delhi, and Dr. Deepak Thomas Abraham, sir, who is the Chief of Medical Staff at the American Mission Hospital Network and also a distinguished professor of surgery, and Dr. Lakshmi Nagendra, who is the Associate Professor and a dear friend from JSS Medical College, Mysore. So their contributions to the field of thyroid research and treatment has definitely been monumental, and we are honored to learn from them today. So to start off, we have an engaging and insightful session with a case presentation by Dr. Ramya. And to moderate the session, I request Dr. Arpan sir and Dr. Nair sir. So over to Dr. Arpan sir and Dr. Nair sir to moderate and to continue with the proceedings.
Okay, thanks very much. On behalf of Dr. Malika and Dr. Avilesh and myself, thanks ITS very much for giving us the opportunity. So Dr. Ramya is going to present the difficult cases of thyrotoxicosis. Our plan will be that like a bedside discussion. When she is presenting, we will be talking and discussing as the case goes through. And we have planned around 18-20 minutes time. We will involve Dr. Malika when the surgery questions will come. And definitely, Dr. Ramya, we need to hand over by 30 minutes. There's already 5 minutes have gone. So all to you, Dr. Ramya, you can start.
Oh, okay, sir. So my screen is visible?
Yes.
Shall I start?
Yes, please.
Good evening, teachers and friends. So I'm going to present a difficult case of thyrotoxicosis managed in our department. We had a 51-year-old postmenopausal female patient whose presenting complaints were a 6 months duration of palpitation and weight loss. The palpitations were regular, present at both exertion and at rest, which was worsened over the last 6 months. There was no history of chest pain or syncope. However, she had dyspnea on exertion amounting to grade 3 NYHA at presentation, with no history suggestive of orthopnea or PND. There was a history of heat intolerance, excessive sweating, and tremor in both hands. There was also a significant weight loss of around 8 to 10 kg over the last 6 months. Along with this history, she also
Go a little bit slowly, Amia. So just one thing now, grade 3 NIHA means what?
grade 3 NYHA means NYHA classification defines dyspnea, fatigue, and chest pain based on the limitation of exertions. Grade 0 means there is no limitation of physical activity. Grade 1 means there is no limitation of physical activity. Grade 2 means there is limitation of exertional activity, which is not usually done.
Unaccustomed exercise.
Unaccustomed
And
exercise.
grade 3?
Grade 3 means regular activities. Patient is having dyspnea or difficulties at doing regular activities. Grade 4 means the at rest, difficulties at rest.
And what is the definition of significant weight loss?
Significant weight loss means more than 5% weight loss over the period of 6 to 12 months.
No, 5% in 1 month and 10% in 6 months. That's the standard definition.
Yes, sir.
Okay, and PND orthopnea, what you are exactly trying to tell? There is no PND, no orthopnea.
No orthopnea. Sir, in a patient with palpitation, presenting with palpitation, one possibility is a cardiac event. In case of cardiac involvement, we are asking other history suggesting other cardiac symptoms like orthopnea and PND, which may be suggestive of a left ventricular failure.
Pulmonary edema. Okay, fine. Okay, please carry on.
So along with this history, she also gives history of swelling in front of the neck, which was present over a period of 2 years, which was gradually increasing in size. But there was no history suggestive of any compressive symptoms and no history of any hypothyroid symptoms. And also there was no history of
Why you are asking hypothyroid symptom? You are presenting a severely thyrotoxic patient. What is the reason?
Sir, there can be, in case of thyroiditis, there can be both hyperthyroid and there can be hypothyroid symptoms also.
Yeah, but you have started with the symptoms of severe
yes,
thyrotoxicosis.
Yes, sir.
And what is the loose stool? What?
Diarrhea can be a presenting picture of hyperthyroidism.
Is it diarrhea or something else?
Hyperdefecation, sir.
Yes, that's not diarrhea by
most
definition.
Yes,
It's more better to tell patient denies the history of altered bowel habit. That way it will look abolished. Because see, the case presentation in MBBS and MD and DM should be a bit of a different. And another thing that lot of no history, the examiners gets a bit upset. Sometimes you could just polish a bit English. The patient denies the history of like this, altered bowel habit like that. Okay, please carry on.
Okay. Yeah. There was no history suggesting a painful eye movements, double vision, redness or watering of eyes, and no history suggestive of a localized thickening of skin anywhere in the body. And in the past history, patient had a history of 4-year duration of systemic hypertension on telmisartan. There was also a history of hysterectomy done at 40 years of age in view of fibroids and menorrhagia. And initially, the patient was evaluated elsewhere in a peripheral hospital, and her investigations showed hyperthyroidism picture with a suppressed TSH and an elevated T3 and T4, suggesting hyperthyroidism.
What is the normal value of T4? This is total T4, correct?
Yes, sir. This is
normal
total
value?
T4. Normal value is 6 to 12, sir. 6 to 12 microgram per dl.
T3?
T3 is 80 to 180 nanogram per dl.
Good. Okay.
The ultrasound neck done elsewhere showed multiple nodules, and there was no history suggesting, there was no retrosternal extension, and a diagnosis of toxic
Go a little bit slowly. I hope you don't mind me asking question. So you wrote microcalcification. What does microcalcification stands for?
Here in the ultrasound, there was no micro or macro calcification. This micro and macro calcification, the importance is regarding the ACR-TIRAD scoring. The calcifications, the macro calcifications will have a score of 1, and micro calcification is more significant with a score of 3.
Okay, and what exactly micro calcification means and what it represents histologically?
Histologically, the calcification, it is Samoma bodies.
Correct. And what exactly means microcalcification means what? You are seeing a microscopic calcification? No. What is that?
3 mm, sir. Less than 3
there is no acoustic shadow. That is the definition.
No acoustic.
Microcalcification, there are no acoustic shadow. But macrocalcification, it will be, and usually macrocalcification is the old hemorrhage type of Carvelian. Now, question is, somebody you are seeing a thyrotoxic people, are you really expect microcalcification?
No, sir.
No, okay. And the spongiform nodule, what does it tell you immediately?
Spongiform nodule carries a score of 0, sir. It is
No.
just a cystic
Benign.
nodule.
Okay, correct, benign. And then you told no retrosternal extension. Can you find ultrasound or is retrosternal extension is there or not?
We can look for the lower border, sir. Lower border, if
Probably ultrasound will be difficult to see. We should not comment. Anyway, it is somebody's report. Academically or scientifically, we should not be commenting on retrosternal extension or ultrasound. Okay, carry on then. Treatment.
So, a diagnosis of toxic multinodular goiter was kept, and the patient was started on antithyroid drugs, methimazole with 20 milligram per day, and a propranolol, beta blocker, propranolol 40 milligram.
And methimazole, is it anything unusual to 10 milligram twice a day?
No, sir. Mainly, based on the ATA guidelines, they recommend giving methimazole, the dosage of methimazole based on the FT4 values. Like 1 to 1.5 times of FT4 value, a dose of 5 to 10 milligram of methimazole is suggested. If it is 1.5 to 2 times, it is 10 to 20, and 30 to 40 in a value more than 3 times.
Very right. But I am talking about twice a day. You can justify or you can tell it is good or correct?
Sir, it can be given as a single dose also, but in an upfront patient presenting with thyrotoxicosis, ATA guidelines recommend giving a twice a day also. Okay,
and propranolol we are giving for?
For the symptoms, sir. Symptoms of the adrenergic symptoms because of hyperthyroidism.
And how it works?
Beta adrenergic, the thyroid hormones mainly increases the beta adrenergic receptors on the target tissues. That is a mechanism for hyperthyroidism.
Number one. So number two, propranolol, how it works?
It also helps in the peripheral blocking the peripheral conversion of T4 to T3.
And in this dose, 80 milligram, how much reduction of the T3 you expect? There is a formula there. With the 80 milligram per day, you expect this much reduction of T3. Roughly, you know?
I don't know, sir.
Okay, that 80 milligram, you expect a 20% reduction of T3, and with 160 milligram, you expect a 30% reduction T3. Okay, diagnosis toxic multinodular goiter. Okay, next.
So after 2 months, the patient again presented with worsening of symptoms of palpitation and tremor in a medicine department of our hospital. And at this point, the patient had persisting hyperthyroidism. However, the patient's investigations showed low total count value with an absolute neutrophil count of 340 cells per cc, which is less than 500 and suggesting agranulocytosis in this background. So diagnosis becomes toxic MNG with agranulocytosis caused by the ATD.
Yeah, that's correct. Now your T3, T4 has almost half is become, but you're worsening palpitation tremor. That is one thing we need to see. But it is somebody's history. I agree. Yeah.
Yes, sir.
Next one.
Meanwhile, patient also had a technetium uptake scan, which was showing a heterogeneous uptake with more uptake on the left side, suggesting a toxic multinodular goiter.
No, 1 minute. How do you want to define? Do you want to modify the diagnosis now?
No, sir.
It is a single hot nodule. So do you want to tell is a toxic adenoma or you still want to tell toxic MNG?
Sir, it is still, I consider the possibility toxic MNG, sir, because there is heterogeneous uptake in various sites, though there was an increased uptake on one area.
Okay. And antibody, TSH receptor antibody, you have
antibodies.
Done. Can you tell, yes, I have done for this and, okay, I will not do for this. What is the reason to getting it done?
Sir, for this patient, there was no indication for doing TRAB as such because it is clear from the picture, it is a suggestive of toxic multinodular goiter. The report was already there, sir. Patient, it was done from the outside.
Yeah, but still, if you ask me, I'll go in favor of toxic nodule, autonomous toxic nodule, plus other nodules probably are euthyroid, the spongiform which you were seen in the ultrasound. Okay, fine. Yes. I carry on. Yeah.
So we have a patient with hyperthyroidism with ATD-induced agranulocytosis. So the management plan was to stop ATD and to maintain the patient on beta blockers. The cholestyramine was also added in order to sequestrate the thyroxine at the GIT level, and lithium was also added at a dose of 600 milligram. And patient developed cutaneous papular eruptions after starting lithium, and so it was stopped and the symptoms improved. So the patient was maintained on beta blockers and cholestyramine.
How lithium works? Mechanism of action?
Mechanism of action of lithium is one thing is, sir, lithium will compete with iodine in the sodium iodide import. It will inhibit the iodothyrosine coupling also. So inhibits the production of thyroid hormones as well as the release of thyroid hormones is also affected.
Right, good.
Sir.
Next.
Okay. So then after that, the patient underwent the first radioiodine ablation with 10 millicurie on October 2022. And post-ablation, we continued the patient on beta blockers and cholestyramine. She went well for a period of 6 months. But again, after 6 months, on February 2023, she presented with another another hyperthyroidism features with worsening palpitation and tremor, and she was admitted in our department. This point again, the patient had tachycardia with bilateral tremor, and the investigation suggested hyperthyroidism. Sir, 1 minute.
What happened?
Sir, there was something with the screen sharing, sir.
Okay. We can see the screen. Investigation.
Yeah, but you have gone a bit front and wants to slide a bit more.
But my screen is not visible, sir.
You also then unshare and then share. Probably that.
Okay, sir.
Cholestyramine, how it works?
Cholestyramine, sir. Cholestyramine will act at the GIT, it form a resin complex with thyroxine and it causes excretion of thyroxine through the feces.
And this is called, simple language, enterohepatic cycle.
Yes.
Yeah, okay, fine.
Yes.
Yeah, the slide before, quickly you can go. I think we are now 8:17. Before slide the clinical data, the slide before this you are telling. Okay, sir, doesn't matter. Carry on.
So the patient had a hyperthyroidism at this point, that is with the recurrent hyperthyroidism, present with the recurrent hyperthyroidism with a T4 of 24 microgram per dl with an FT4 of more than 7.8 nanogram per dl and suppressed TSH. So at this point, we have a patient with recurrent hyperthyroidism who cannot be treated with ATD because of agranulocytosis. So our management strategy was to continue the patient on cholestyramine, steroids, and beta blockers, and also to consider the possibility of radioiodine ablation this time. We do not want to consider surgery upfront as in a definitive management of recurrent hyperthyroidism because we do not want the patient to end up in thyroid stone. But with these strategies, we were not able to bring down the thyroid hormone levels. So we planned to proceed with plasmapheresis. Yeah, 1 minute. So dexamethasone, what is the appropriate dose? Or is betamethasone better than dexamethasone in this situation, and how it works? Sir, steroids, dexamethasone are mainly given in order to, the basic mechanism is one is it will inhibit the peripheral conversion. The T4 to T3 peripheral conversion is inhibited. Then steroids, in case of a thyroid storm, it is also advised mainly because of the adrenal insufficiency which can happen along with this hyperthyroidism.
Okay, that is a different direction. So you think the patient has thyroid storm?
No, sir. No, sir.
I'll come to thyroid storm. So propranolol dose 40 milligram twice a day could have been increased?
Yes, sir. Yes.
Okay. We actually give the betamethasone 2 milligram 4 times a day, but whenever we are treating accelerated thyroiditis, that's okay. That is fine. Okay. Please carry on. Yeah.
Okay. So, so this plasmapheresis, the American Apheresis Society recommends plasmapheresis to be considered in patients with hyperthyroidism who could not be managed otherwise with ATD. So we started the patient on plasmapheresis. With the first plex, there was a fall in value from 24 microgram per DL to 16 microgram per DL with the first plasmapheresis. But then with the subsequent plasmapheresis, patient underwent, unfortunately, patient developed chest pain and hemodynamic instability. She was managed in the critical care unit with anticoagulation as well as inotropic supports, and a diagnosis of stress-induced cardiomyopathy was considered. And only after stabilizing the patient with this event, we could proceed with the second radioiodine ablation.
What is stress-induced cardiomyopathy? What is this? Is it medical word or Times of India wording? You think now this is thyrostorm?
No.
What is the definition of thyrostorm and how do you diagnose?
Thyroid storm is characterized by the biochemical evidence of hyperthyroidism with patient developing symptoms.
Symptoms of what?
Symptoms of hyperthyroidism.
No, that will be there.
Any scoring is there, Ramya?
Yes, sir. It can be defined by, there is a Burch-Wartowski scoring system.
Correct.
Where multiple levels are being assessed. One is the temperature, then the central nervous system, the present sensorium consciousness, then GIT, presence of vomiting, jaundice is considered.
Cardiac.
Then cardiac in the form of tachycardia and also presence of atrial fibrillation and also precipitating factors, presence or absence.
So what score is diagnostic of thyrostorm or suggestive?
Scoring more than 45. 45 is more suggestive.
So in simple word, organ system dysfunction.
Yes, sir.
Has to be there to diagnose thyroid. That's what you are telling. CNS gastrointestinal. Now I have an organ system dysfunction. Why can't I tell this is thyrostorm? Patient is an ICU patient, is a severe cardiac, thyrocardiac problem. All the TROP-T, at this point, you need to be quiet about the TROP-T.
Yeah, yes, sir.
Okay, fine. Next. Carry on, yeah.
Sir, so the patient underwent the second radioiodine ablation with 15 millicurie on March 2023. Then within 1 week after radioiodine ablation, the patient had an increase in T4 levels, which could be due to the radiation thyroiditis. But then it was managed with the oral steroids. So far we have treated the patient with ATD, and after development of agranulocytosis, we proceeded with radioiodine ablation, and under the cover of plasmapheresis, a second dose was also given. So far, this is the timeline.
And this is prednisolone 5 milligram. Is this prednisolone is the correct steroid?
Prednisar, for radiation thyroiditis, the ENM guidelines recommends prednisolone at a dose of 0.2 to 0.3 mg per kg to be started 3 to 5 days after radioiodine ablation and to be tapered off for a period of 4 to 8 weeks.
Right, good.
So during the follow-up of the patient, again, she was okay for a period of 6 months, but after 6 months, she ended up again with a third recurrence. At this point of time, we have convinced the patient to proceed with surgery, but then the patient and the bystanders, mainly because of the recent cardiac event, they were not willing for a surgery, and we had no other option but to proceed with the third radioiodine ablation. And during the follow-up period after that, we convinced the patient and finally she underwent surgery by December 2023. She underwent a total thyroidectomy.
Can you have a comment from Dr. Mallika now? This is the right time. I wanted her to comment about this. How much risk you can take, because you want somebody to be euthyroid for your, you need to unmute, madam. You want somebody to be euthyroid for a nice surgery, but this is a difficult situation. So how far thyrotoxicosis you agree? You need to unmute yourself, madam. Oh, we can't hear you. You unmute in that microphone icon, audio icon.
I wanted to ask her, while the patient was in ICU, and because the diagnosis is only clinical, this is not, we don't even wait for the labs if we are wanting to treat the patient. Then at such a time when the patient has already undergone one episode of thyroid storm, we want to convince the patient at that time, maybe we want to stabilize them. And once the stabilization has happened, we cannot wait for euthyroid status, but we can do something else in order to prepare her for surgery. What is that? Are you aware of that?
Yes, a preoperative preparation can be done with steroids, beta blockers, and iodine.
Yeah, this is called the rapid preparation.
Yes,
So, what is that rapid preparation? What kind of iodine and what is the dose?
Iodine, we have Lugol's iodine is available where 1 drop contains 6 milligrams of iodine. And a saturated solution of potassium iodide is also available with 1 drop carrying 38 milligram. So the recommendation is to give 2 to 3 drops of 2 to 3 drops of SSKI, and then surgery should be done within 10 days of
Every 8
preparation.
hours. Yeah.
Yes, madam. Every 8 hours. And
All
within
right.
to proceed with surgery within 8 to 10 days.
Correct. So was this option given to the patient?
Yes, madam. Yes, madam. But they were not willing. We took
Okay.
another 3 to 4 months to convince them to proceed with surgery.
Okay. I also wanted to ask, on examination, did the patient have any other risks of difficult intubation, or do you understand the risks of difficult? When do you anticipate a difficult intubation?
Is it anatomical, madam, like obesity?
It is something to do with the thyroid swelling.
Thyroid swelling. When the large size of swelling can
Displacement
have.
of the trachea. That's what
Correct. There are long-standing swelling
Long
or
stand. There can be tracheomalacia.
accumulation. Yeah.
correct, and something that has that maybe encircles the trachea, the size of the swelling, the consistency of the swelling.
Yes.
So these are the things. If in addition to all of these things, the patient was unwilling and also was a risk, there was a high risk of difficult intubation, then one can still consider another round of radioiodine ablation, but there is no other scenario.
Yes.
When now finally the patient has undergone total thyroidectomy?
Yes, madam.
Okay. So
And after
during the course of surgery, what were the changes that you had to, what were the risks basically that you thought that the patient could, the complications from anesthesia point of view as well as surgery point of view?
One point was regarding the thyroid storm, madam, regarding the precipitation of a thyroid crisis. Then, then also a hemodynamic instability on the background of a recent ACS.
Absolutely.
Then patient can have arrhythmias again as part of thyroid crisis.
What arrhythmia is the commonest?
Most common is the sinus arrhythmia, atrial fibrillation. Atrial fibrillation.
Correct. And is there anything else that the anesthetist worries about? Is there any electrolyte disorder that most of these patients?
Hypokalemia. Hypokalemia can.
Yeah. And is there also any other drug interaction, certain drugs that we cannot use in these patients?
Agents.
Okay, maybe
propofol.
Correct.
Propofol can have BP, hypotension.
Correct. So both hypotension and hypertension because of the exaggerated response of the sympathetic system, the catecholamines. That is why we avoid all of the sympathomimetic drugs.
Yes, madam.
And now from surgery point of view, now we are going to operate a patient who has already undergone 2 rounds of RAIs, has already had probably some cardiac factors which have already made him a poor operative risk. Now, what are the things that we will think about while we are taking this patient for surgery?
One thing is it, madam, regarding the fibrosis part, because of the radioiodine that can produce beta and gamma radiation can cause destruction of the thyroid follicles. There can be necrosis. And
so during surgery, what are the things that can go wrong because of this?
Is it regarding the the removal?
Also, maybe regarding the complete removal becomes difficult. Besides that, the removal becomes difficult because of the recurrent laryngeal nerve and the parathyroids that we are preserved. So, any patient who has already undergone RAI 2 times, we are already anticipating some amount of damage to the parathyroids.
Okay.
So, the patient may develop post-op
hypoparathyroidism. Okay.
And so that has to be anticipated. Sometimes it happens as quickly as within intraoperative
Okay.
while we are operating.
Okay.
The second thing is because of the recurrent laryngeal nerve. The recurrent laryngeal nerve may get, because there's fibrosis, there can be injury to the recurrent laryngeal nerve, which will present as
Voice, patient can you vocal cord palsy and
yeah. So what will happen intraoperatively? See, voice we will see only post-operatively once we've successfully extubated the patient. But we may not be able to
stridor. Patient can have stridor.
Correct, absolutely. So these are the things that we need to think about. Let's go ahead.
Next slide.
So the patient underwent a total thyroidectomy, and the patient did not have post-operative hypocalcemia. Currently, her hyperthyroid symptoms are relieved, and now she is on thyroxine replacement. Thyroxine replacement doses.
Yes.
Sir.
In the total thyroidectomy specimen.
Yes, madam.
We will probably not have a photograph of that, right?
No, madam, we didn't have.
It was were they able to find a single nodule, or was it multinodular? What was the report?
The report was given as multinodular, madam. Multinodular.
It's not a what nodule, it was a
no. It was a multinodular specimen.
Okay. So multiple areas had follicles.
Yes.
Which were hyperfunctioning.
Ah.
Okay. Now that the patient has undergone total thyroidectomy, what do we do on the next OPD visit?
One thing is regarding the we can ask the symptoms, the change in the voice can be asked, and regarding the biochemical status, TSH optimization is one thing we have to do, and we can keep it since this is a multinodular goiter, not a malignancy. We can keep the TSH safe in the range between 0.5 to 5 microunits per ml.
Excellent. And how often do you get these labs done? When do you ask her to come for the next visit?
We'll ask them to visit every 3 months, madam, 3 to 6 months. No, if it is not a malignancy, I mean, if it is just a multinodular goiter, in the follow-up visit TSH can be done every 3 to 6 months. Okay, but initially to optimize dose, you will have to.
I'm asking about first follow-up visit when you leave.
First follow-up visit, yeah. You have to call
4
it
to 6.
Exactly, after every 6
4 to 6. Okay.
And also delayed hypocalcemia because the patient have received multiple RAI, so we'll need to check a calcium albumin.
Yes.
Okay, I think Abhilash will stop here because we are crossing the time.
Yes, sir.
Okay, thank you very much. On behalf of us all, Dr. Abhilash, Dr. Mallika, that we declare you are fit to go for final examination. You are completely ready. Thank you very much. It was a nice presentation. You answered all the questions very nicely. Over to you, Ganvi.
Yes, sir. Thank you, Dr. Ragna, for a very engaging and informative case presentation. And a special thanks to Dr. Arpan, sir, for declaring Dr. Ramya fit for exams, and Dr. Nair, sir, for their valuable insights and moderation as well. So I also thank Dr. Mallika for her wonderful moderation as well, ma'am. Thank you, ma'am. So now let us proceed to the keynote talk, that is the surgical management of medullary carcinoma of the thyroid, led by Dr. Deepak Thomas Abraham, sir. So I request the tech team to display sir's CV. To moderate the session and introduce the speaker, I again invite Dr. Mallika Danda, madam. Over to madam. Tech team, can you please display Dr. Abraham sir's CV?
Yes, ma'am.
Yeah. Malika Madam is the consultant breast and endocrine surgeon at Delhi. I request Madam to introduce Dr. Abraham, sir. Tech team, please display Dr. Abraham, sir. Yeah.
Everybody knows Dr. Deepak Abraham, sir. He is the Chief of Medical Staff at the American Mission Hospital Network, Medical Director of the King Hamad American Mission Hospital, the Chair, Department of Surgery, Professor, Department of Surgery, Royal College of Surgeons, Ireland Medical University of Bahrain. Now, he's been the Chief of Medical Staff and Medical Director at American Mission Hospital Network. He's leading a 200-doctor workforce and executing a 10-year strategic plan. He led the King Hamad American Mission Hospital to become Bahrain's first Mayo Clinic Care Network member in 2024. First, Deepak sir has been at CMC before that, and he has had great things, done great things. We are all aware of it. I congratulate you, sir, and I am honored to welcome you here. And please, we can hear you talk on medullary thyroid cancer.
Thank you, Malika. I mean, sometimes these prefixes and postfixes don't define you. It's who you are who defines you. And in my role here in Bahrain does not qualify me to become a speaker on medullary thyroid cancer, but it's primarily because of my role in the past when I was the senior professor at Christian Medical College Vellore in the Department of Endocrine Surgery, and my special interest in MTC when I did my clinical and research fellowship, including a PhD at Sydney, at the University of Sydney in Royal North Shore Hospital. So could I share my slide next? And yeah, and then if that's ready to go, I could show that. Yeah. Okay. So I mean, I've taken the liberty of actually changing the title from surgical management, thinking of the audience. And the audience, I realized, was a mixture of endocrinologists and multi-specialty people who work with thyroid disease. And so I brought in a medical component into it, and that is RET testing and its implications. And of course, it definitely also includes the surgical management. My role here in Bahrain is actually transition from becoming a surgeon to becoming more of a leadership in healthcare. And that was a career choice I made maybe at the peak of my surgical career, but that's to increase longevity of life in whatever you do rather than just be caught up in what you're doing daily. But that's personal preference, and I must say that it's a choice we all make at some point to consider the move. But medullary thyroid cancer is something which is close to my heart, and it's something which I've understood the disease well, and also to understand how genetics and how you could prognosticate and also predict how it behaves in the family and in other kindred members who have the genetic mutation, but the disease is not yet manifest. And you could cure them, and it's a wonderful feeling to have a family who comes to you where you have prevented a cancer from coming. So this is a proof of a surgical prevention of malignancy, or surgical removal, which is a prophylactic surgery. Medullary thyroid cancer is rare, extremely rare. Current ATI guidelines and also the literature shows, and it's dropped from 4 to 5% to 1 to 2%. And it's not because it dropped by numbers; it's actually because the relative increase of the PTCs. That's because of ultrasound and the diagnosis which comes out of that. And but that's more interesting. 15 to 20% of thyroid cancer related deaths are due to thyroid cancer, due to MTC, and lack of response to other modalities of treatment make it a challenge. And so the surgery is very crucial. And the first surgery is the best surgery. And when you have a locally advanced thyroid cancer, then first surgery may not be the best option, and you may consider a neoadjuvant treatments, and that is with TKIs. And this is one area where literature is coming out to say that patients can be treated with neoadjuvant TKIs before you actually go in for surgery. And we've had experience in Velo in doing that. By the way, the data I'm sharing, the numbers, and actually from a publication in 2018 when I was a senior author of that publication. So the data is actually CMC Velour's data. It's the data when I was working there, and I'm taken the liberty, and I'm sure that I acknowledge the fact that this is CMC's patient database, which I have used for this presentation. And choosing and doing the right operation is crucial in medullary thyroid cancer. And as you would know, that it arises from the C cell as opposed to the thyroid follicular cell. And C cell is located at the posterior most aspect of the thyroid gland, where the tubercle of Zuckerkandl is. So a complete thyroidectomy is very essential and very critical, and that's where the nerve is closest. And I just heard about recurrent laryngeal nerve palsies, but this is something where you leave behind disease, you leave behind and the recurrences can happen and leave behind tumor itself if you've not done a total thyroidectomy. By literature, it's 75% of them are sporadics. That means they do not have a germline mutation, but hereditary is 25%. But when you look at current literature of many publications, you'll find that that percentage of hereditaries are going up to about 30, 31, 33%. And that is because of routine testing of the RET gene. And in the hereditary, you have the familial MTCs as well as the multiple endocrine neoplasias 2A and 2B. Right. In the current classification, you know about the MEN2A syndromes and the MEN2B syndromes. There are 4 variants in the MEN2A. And there's a classic variant, the one with cutaneous CLA, the one with Hirschsprungs, and the isolated familial MTCs. And the MEN2B syndromes are the most rare. And this is linked to the mutation in the gene. And the RET gene consists of 21 exons, but the mutations we look for in the exons 8, 11, 10, 11, 13, 14, 15, and 16. And routine screening is standard of care. And that is why the percentage of mutation, which seemingly sporadic, but then actually you have a mutation in those patients, which then make them hereditary group, and then you screen the family, and you can even identify patients who have the genetic disease, but not the somatic manifestation of the disease yet. So PCR amplification of the germline DNA obtained from the white blood cells is what we use for the testing, and this has become standard of care for patients with MTC. This is 2013, but you can see that this is even now mutations in exon 5 are being picked up, and you have Greek families now being reported in exon 8. So you have a whole host of mutations, but when you can't remember all this practically, and I'll give you a tip of how to remember these mutations by looking at the codon. And but RET screening has revolutionized treatment for MTCs, and you can offer prophylactic surgery to carriers of the mutation. And as I started, MTC is the near perfect model for primary prevention of cancers in humans by a surgical extirpation of a gland. Something close to that is what's happening in FAP in the colon, but this is a more robust mechanism, and there are reasons why that works well. Why is MTC a perfect model? It's also because the near complete penetrance of if the mutation is there, then family members, 97 to 99% will develop the disease. And it's a highly reliable test. It's also the organ at risk is expendable. That's the thyroid, but you do it well, and you need a good thyroid surgeon to take care of that. And finally, replacement therapy is available at a cheap cost. And so if you can get all these factors make the removal of the thyroid gland for MTC as a prophylactic surgery as a good, perfect model. And we have this test, which is reliable to determine if the operation has been curative, and that's a serum calcitonin. And that it's a sensitive marker to tell you that the disease is well handled. Yes, it's the removal of the at-risk organ is the prophylactic surgery prior to clinical manifestation of the disease. And also there's a clear age-related progression from C-cell hyperplasia to invasive MTC. And you catch them in that stage before they become invasive cancers, you will see that you have cured the patient. Now, with regard to this is what the risk, which is the genotype-phenotype correlation, and you have the three risks, moderate, high, and the highest. In the highest, you have only one, which is the 918, and in the high, you have 2, 634, and 883. So if you remember these three, and you hear a number which is not these three, then all of them are moderate. So if you remember 918 and you remember 634 and 883, you need not remember anything else because everything else falls in the other bucket, which is moderate. And so, it's only now where, where in the high and the highest risks where you have to consider prophylactic surgery at 5 years or less than 5 years or as early as possible in 918. Again, serum calcitonin is a good guide. And we've had actually families who've had their serum calcitonins checked and they've stayed to 10, 12, 14 years or even longer before they are considered for surgery. So families choose to do that, but the index case and when the presentation on the index patient happened is a rough guide to tell the remaining family members also will develop the disease at that time. So anyway, most of the MTCs we see are in the adult, but especially the 918 can happen in the younger age. Who should undergo RET testing? Everybody. Everybody who's got a diagnosis of MTC on FNAC should undergo a screening with the RET testing, along with all the other biochemistry workup which you would do. And so irrespective of the fact, is it hereditary, is it sporadic, that's not the decision. It's based on the FNAC testing, which tells you, okay, this patient has got the MTC, then it's good to have your RET testing report before you actually go for surgery. Practically, I know that's a problem, but in Vellore, we had reached and refined it so well that we had the report in our hand before we actually went for surgery because we were able to get the turnaround time of the test in 10 days. And so when you get the report in 10 days, it changes the whole management and also counsels the family as to how we go forward with it. And I'll tell you what we've done, and we've been actually CMC has been publishing on the RET data from 2009. At this point of time, I was in Sydney doing my MTC PhD thesis and my fellowship, and this was the first. This is a DBT grant where we got a grant to do the study, and we had proven. We did this mutational analysis of the exons 10, 11, 13, 14, 15, 16, but we started exon 8 in 2012. And this was published. And this data was still 2017, and this publication came out in 2018. So I can confidently share this data because this was part of that publication. And that was 146 patients. We had 75% of them who were sporadics and 25% familial. But look at the data. This is what the published literature says, but we had 33% of them were familial, and because we screened everybody. And so, and the mutation patterns where the 634 was the most common mutation, 804 was the next common. Thankfully, 918 was less common than that. So the mutation pattern is also consistent with the Western literature, where 634 is the most common mutation. And we observed about 64% of them had metastasis at the start of disease. So that shows that most patients at the start of the treatment itself have got locally advanced or metastatic disease in the neck itself. So they've come outside the thyroid gland. Now, what we did was RET testing became something like, we became crusaders for this test. And you can see we went around in various conferences in various parts of the country, both the surgeon and the molecular pathologist, when we started speaking. You can see that we had people referring samples into the lab, and we were able to get the testing done. For many people, by samples being sent to us. And this is Rekha Pai. Rekha Pai and I, this I think was a meeting in Gujarat where we presented our data, and to show that we actually could convince people to say it was not too expensive. It was around, at that point, about 11,000 to 12,000 rupees to get the genetic testing done. And they would get a turnaround time. All they needed to do was collect a sample in an EDTA tube and courier that to the lab, and they would get the report in the next 2 weeks. So this is what we did. We had a retrospective review of those patients. We had all patients diagnosed with MTC with mutation positive carriers, and the exclusion criteria were all the non-medullary thyroid cancers. And we had 4.5% of them were, MTC. We had 2022 in the same period. We had thyroid cancers, and you can see that most of them were already goiter plus lymph node. That means they've spread outside the thyroid gland. And even though we were crusaders for this, we still could not get 100% testing of the RET, and we got 78.9%, which was commendable at that point of time, because still people, this is almost a decade ago, so people were still not convinced that you should be doing this test, even though they were good endocrine surgeons. And so we in our group, we've had 35.2%, and you can see the increase from 31% to 35.2% from 2009 to 2017 data, which shows that the increase in testing will obviously increase your percentage of, you'll pick up the percentage of RET positive patients. And the most common was the 634, and this was 25 patients in the 71 who had the mutation positive. And we screened the kindreds. So that means you had 12 patients, there's 25 patients, 10 of them brought their kindred. So 10 out of the 25 were brought family members who could be screened. 15 came forward. 8 of the 15 were positive, and 6 out of the 8 underwent surgery, and 4 out of the 6 were prophylactic. That means 2 had disease. So that means even though you're screening and picking up, even when you do the final surgery, you have an invasive MTC focus within the gland. So that's important to show that how important it is to actually do the screen well and screen diligently for all family members, and you pick them up earlier. So these patients who underwent prophylactic surgery, still you'll find a focus which has invasive cancer within them. And this was what shows that, when we did the analysis between hereditary versus the sporadic group, you see that the sporadics had a significant increase in lymph node metastasis at the time of presentation as compared to the hereditary group. And also the pre-op calcitonin was higher in the patients who had in patients who had the sporadic. So based on the kind of dissections we did, the selective neck dissection was more in the sporadic group, and also the mean post-op to calcitonin was higher in the sporadic group. So basically saying the sporadic group has got an aggressive disease or a more advanced presentation at stage. But however, if you capture these patients also when the disease is confined to within the thyroid gland, you can cure them. We've had patients who've had a calcitonin of 900, but when they finished surgery and the disease was confined to the thyroid gland, their calcitonin was less than 2. And they've been on a follow-up for years, and their calcitonins continue to be low. And you can see that even our survival or mortality was higher in the sporadic group. If I'm not mistaken, the current updated version of this publication was presented at the last International Association of Endocrine Surgeons. Pushkar was, I think, the first author of that paper, and it will be soon coming out in print. This was the paper which was presented or published at that point of time when I was the senior author on the paper. Right, now coming to, this is a very interesting trivia. Abraham Lincoln was supposed to have this disease, though there was no genetic testing at that point of time. But you know that there's no Lincoln alive today because they all died in their childhood. Their children were not alive. And so in this family tree of Abraham Lincoln, there is nobody still alive in the tree because all of them had passed on from some disease, but they were not clear about thyroid disease. But anyway, there's a whole host of literature on this and makes interesting reading. And there's a Physical Lincoln, a book called Physical Lincoln, written by a cardiologist whose passion was actually write about the medical history of American presidents. And it makes fascinating reading, which actually spurred me in my journey on MTC to read about Abraham Lincoln and the possible meant to be he had. Well, in the Indian setting, doing prophylactic surgery, there's a social barrier, there's a cost issue, poor literacy, education, and there's a cultural issue. Patients do not want to be known as familial disease, do not want, because there's a whole host of problems which come up. I'll tell you my own patient. In 2014, when we operated on him, he came with insurance cover. And when we found out, and we had to do a major surgery after giving him neoadjuvant TKIs, and we had to do a sternotomy, and he had a surgery which was about 14 hours to remove his disease. He's still alive so many years later, but his insurance knocked him off because he was hereditary MTC. So, these are all the cultural and the barriers which we face in society when you talk about something which is genetic. And inadequate decision-making capacity of patients, and patients will tell us, "Aap Bhagwan hai, aap bataiye kya karna hai." So often they tell you that, but often, we have to educate them to bring them to our level of education to say what is important for them. So I'll stop here and I'm happy to take questions. RET mutation analysis is standard of care in MTC, and RET testing in a resource-poor setting requires proper counseling. Screening of kindred presents a social challenge, and prophylactic surgery poses an additional challenge to the clinician. Thank you, and I'm happy to take some questions.
The tech team, do we have any questions by the audience?
No, ma'am. As of now, nothing. No, ma'am. As of now, we don't have any.
Okay.
So why don't you tell us a little bit about familial MTC, the FMTC?
Yeah, okay.
Meant to be and meant to be.
So
how do we define it? Is it just a diagnosis of exclusion?
Isolated FMTC, there are two definitions. One is a more stricter definition where you find, say that in generations, up to 4 generations, there's only manifestation of disease in the thyroid gland and no associated hypoparathyroidism or pheochromocytoma. So in fact, I think 4 generations of only thyroid disease, and then you could say that is an FMTC. But then if you have your RET testing and your mutation analysis, which tells you the codon in which it is, then you can go back to the reference library, and that will tell you whether this patient belongs to FMTC or not. Right? So that's how we defined it. So we took the codon mutation, we went back to the library to see, and you can see that actually in the ATA, it's published guidelines to say this is only PHEO. This is only MTC. This is MTC with PHEO, with para, at this age, at what age. So it becomes easier. And I used to just use the reference point within the library to say this is FMTC or not. So, however, we did screen them at the start, we did screen them for both pheochromocytoma and hypoparathyroidism before you operated.
So what about the role of theranostics in the management of MTC? Like,
You're talking about receptor
yes, sir,
like
peptide receptor-based
yeah.
therapies. Yes, sir.
Yeah, see, I can tell you from practical experience, we've used lutetium and MIBG, right? MIBG was the more cheaper version, which was there before lutetium came into the picture. Our experience was not so great with lutetium. Actually, we had some experience with MIBG, and we've actually treated even malignant FEOs with MIBG, and we published that data when we from Velo. However, I will say TKIs have changed the game. TKIs have really changed the way we can manage patients with MTC. But TKIs are meant at a stage when you've got disease which is, progressive, symptomatic, non-resectable. That's when you're thinking of bringing in, use of TKIs. And then you have the more RET-specific TKIs, pralsetinib and serpercatinib. In fact, the one I mentioned briefly about the patient who who got rejected by insurance because of his diagnosis of hereditary was diagnosed with 634 mutation in 2014 with locally advanced disease both in the neck and in the mediastinum. So at that point of time, we had only one TKI available, and that was the first one in the whole group, and which is a Bayer Health product at that point of time, and we used it for 3 months in a neoadjuvant setting after discussing in our MDT, and repeated the scans and saw regression of disease. Went back in, operated, took out his thyroid gland, his neck disease, and his mediastinal disease, and put him back onto the TKI, which continued for a period of 3 to 4 years, and then slowly calcitonin dropped from 30,000 to 4,000, and then slowly started rising and went up to 11,000 and 18,000. And then he was searching worldwide for world clinical trials for MTC, and the patient himself told me about a trial which my boss in Sydney was on that trial, my supervisor for my PhD thesis. And so because of that, I got him onto the trial by, enrolling him in Singapore, which is a multicentric world trial. And because of that, he got serpercatinib for life. And what happened was his 18,000 serum calcitonin after starting serpercatinib, it was called the LOXO 292 trial. He dropped from 17,000 to 170. And today in 2025, he's still alive. And he keeps getting this drug from the trial. And he's alive simply because of TKI. And that's the story. That's the power of what TKI can do. So, in fact, because of him, he connected to many of my own patients who had MTC, and they started a group among themselves. It was like a support group. He got another guy enrolled in a trial in Pune, which for some reason was running out of Pune. And that was also a multinational trial. And he got that guy enrolled in the trial because of the networking patients had. And MTC being such a rare diagnosis, it is important to realize that support can happen from many angles, not only from your physician, but also from the patient themselves.
So thank you, sir. Thank you. Thank you. I think TKIs, as you said, have definitely been a game changer, and probably they hold much more value than the the peptide-based receptor therapies. Yes, sir. So since there are no more questions, so with your permission, can we conclude this session, sir? And shall we move on to quiz? Yes, sir. So I thank Dr. Deepak sir for delivering such a insightful, clear, detailed presentation, and also sharing his sir's own data as well on MTC. And tech team, can we have the presentation, please? For those who are again interested and passionate about thyroid research, we encourage you to submit the work on thyroid research and practice, and also we encourage you to become a reviewer as well. Scanning the QR codes displayed on the screen will help you learn more about this. So now let's move on to an exciting quiz session. So before we move on, can we have the display of the quiz rules, please? Yeah. So to participate in the quiz, click on the button, that is the Attend Quiz button given on the screen, which is being live streamed. The quiz will be conducted through a platform called as a Slido. You're requested to use a laptop for the ease of experience, and the quiz will run for about 5 minutes. The quiz master will display the case or the description of the question by screen sharing a PowerPoint file. There'll be 10 questions. Each question will be available for about 30 seconds with the timer on, and do not refresh the page or go back into the page. So to conduct the quiz, we have our quiz master, Dr. Lakshmi Nagendra, who's a very dear friend of mine. She's an associate professor in the Department of Endocrinology. So she has many achievements to her credit. So I request Dr. Lakshmi Nagendra to conduct the quiz. The participants get ready to test your knowledge and compete for top honors for the quiz conducted by Dr. Lakshmi Nagendra. So over to Dr. Lakshmi.
Thank you, Dr. Ganvi. I'm just sharing my screen now. Is the screen visible?
Yes, yes, yes.
So all the best to everyone that's participating, and these are very easy questions and something.
Ma'am, wait for more 2 minutes, no?
Do we wait?
Yes, Dr. Lakshmi.
Yes,
I
ma'am.
think.
More 2 minutes you have to wait, ma'am, because they are joining.
Okay.
Tech team, are we good to go now?
Yes, ma'am, you can.
Okay, thank you. So I was saying that these are designed to test what your routine clinical knowledge of what you do in the clinics every day. So all the best, and this is the first question. So a 36-year-old woman presents with a neck swelling of 3 months duration, undergoes a thyroid ultrasound. On ultrasound, there's a solitary thyroid nodule of size 1.2 centimeters. The nodule has the following characteristics. It's of mixed cystic and solid composition, hyperechoic, wider than tall, with macrocalcifications and lobulated margins. There is no extrathyroidal extension. So TIRADS scoring of this nodule would be, is it TIRADS 3, 4, 5, or 2? So I'm just going to pause for 20 seconds for you to answer.
Next.
So this is the second question. If you come across a TIRADS 3 nodule, what would the indication for FNAC in a TIRADS 3 nodule would be? Is it size more than 1.5 centimeters, size more than 2 centimeters, size more than 2.5 centimeters, or size more than 3 centimeters?
Next.
Okay, going on to the third question. So squamous cell carcinoma of the thyroid is classified as which of the following? Is it a subtype of poorly differentiated thyroid cancer? Is it a subtype of anaplastic thyroid cancer? Is it subtype of high-grade follicular cell-derived anaplastic thyroid cancer, or is it a subtype of encapsulated follicular-derived thyroid cancer? Okay, going to the next question. This is question 4. So you see a 56-year-old woman who is seen post-total thyroidectomy. Histopathology is suggestive of thyroid cancer with macroscopic invasion of tumor into perithyroidal soft tissues. There is no evidence of distant metastasis. What is the target TSH? So this is DTC. And histopathology is suggestive of macroscopic invasion of tumor into perithyroidal soft tissue. So initial target TSH in this patient, would it be between 0.5 to 2 or 0.5 to 0.1, less than 0.1 or less than 1? So going on to question 5. So a 28-year-old woman undergoes total thyroidectomy for histologically proven medullary thyroid cancer. So at 3 months follow-up, when she's seen post-op at 3 months, calcitonin is 100 picograms per ml. What is the appropriate management in this patient? Is it A, radiological biochemical follow-up in 3 to 6 months, B, imaging studies to look for metastasis, C, repeat surgery, or D, genetic testing?
Next one.
So this is the landmark tablet trial, which studied the use of LT4 supplementation in euthyroid women with positive thyroid peroxidase antibodies and a history of miscarriage or infertility. So what was the conclusion of the study? So supplementation did not result in a higher rate of live births than placebo. Option B is resulted in a higher rate of live births than placebo. C is did not result in a higher rate of live births, but resulted in lesser maternal complications. D is did not result in higher rate of live births, but resulted in higher maternal complications.
Next one.
So going on to question 7. So a 28-year-old euthyroid woman with history of hemithyroidectomy 3 years back presents with 6 weeks of amenorrhea. Urine pregnancy test is positive. What is the correct approach regarding monitoring of thyroid function test in this patient? A, no increased surveillance is required. B, TSH measurement in every trimester. C, TSH measurement at the first pregnancy visit and every 4 weeks thereafter. And D is TSH measurement approximately every 4 weeks until mid-gestation and at least once near 30 weeks gestation. So going on to question 8. A 26-year-old woman with a history of hypothyroidism on levothyroxine replacement on 125 micrograms per day is seen 1 day post LSES. So what is the recommendation for levothyroxine dosing and monitoring in this patient? So is it A, continue same dose and monitor 12 weeks postpartum? B, reduce levothyroxine dose to the pre-pregnancy dose and monitor 6 weeks postpartum? C, reduce levothyroxine dose by 30% and monitor 6 weeks postpartum, or D, continue same dose and monitor 6 weeks postpartum? So going on to question 9. A 68-year-old woman is seen for subclinical hyperthyroidism. She's asymptomatic. T3, T4 is normal on several occasions, but TSH is persistently less than 0.1. She does not have any comorbidities. BMD is normal. So what is the appropriate management? Is it A, treatment with antithyroid drugs? B, monitor TFT after 3 months? C, rule out central hypothyroidism? Or is it D, thyroid scintigraphy? So going on to the last question, question 10. A 69-year-old woman with incomplete biochemical response to methimazole is planned for radioiodine therapy. Her pulse rate is 78 beats per minute. So which of the following is appropriate in the management of this patient before radioiodine therapy? So start on beta blockers, stop methimazole 2 to 3 days prior to radioiodine therapy. Start on beta blockers, continue methimazole. Continue methimazole, beta blockade is not required, or start on beta blockers, stop methimazole 1 week prior to radioiodine therapy. So can we stop? Can I stop sharing now? Yeah.
Yes, ma'am.
Yeah.
So can we go on to the answers?
Yes, yes, yes. Yes, yes. I request you to share the answers.
So the answer to question 1 is this is TIRADS4. The nodule was mixed cystic and solid, which gives it 1 point. Hyperechoic, which gives it 1 point. Lobulated or irregular, which gives it 2 points. Macrocalcifications gives it 1 point. So total of 5 points, and 4 to 6 points would place the category, place the nodule under category of TIRADS4. So going on to question 2. So the indication for FNAC in a TIRADS3 nodule is size more than 2.5 centimeters. So in TIRADS3, you FNA if size is more than 2.5 centimeters. In TIRADS4, you FNA if the size is more than 1.5 centimeter. In TIRADS5, you go on to FNA if the size is more than 1 centimeter. So question 3, squamous cell carcinoma is actually a subtype of anaplastic thyroid cancer. So this was in the recent WHO 2022 classification of thyroid cancer, because a large majority of squamous cell carcinoma of the thyroid have the BRAF mutations and exhibit TTF1 and PAX site immunoexpression, so proving the follicular cell origin, and hence it was placed under anaplastic thyroid cancer. So answer to question 4. So a 56-year-old woman, she is seen post-total thyroidectomy for DTC, and histopathology suggestive of macroscopic invasion, but there's no evidence of distant metastasis. So when you look at macroscopic tumor invasion, the patient's initial risk category would be high risk. And when we look at the ATA guidelines for the initial TSH goal in patients with high risk, it is less than 0.1. Going on to question 5. So a 28-year-old, she undergoes total thyroidectomy for medullary thyroid cancer. So at 3 months, calcitonin is 100. So this is the American Thyroid Association guidelines for the management of medullary thyroid cancer. And if you see that if the calcitonin is detectable but less than 150, and there's no evidence of persistent or recurrent MTC, you go on to measure calcitonin and CA every 3 to 6 months, and physical examination and ultrasound of the neck every 6 months. So it would be monitoring. But if the calcitonin is more than 150, you straight away go on to do imaging procedures to detect metastasis. So this is a tablet trial, and this studied the use of levothyroxine supplementation in euthyroid women who had positive thyroid peroxidase antibodies bodies and had a history of miscarriage or infertility. And this study showed that the use of levothyroxine did not actually result in a higher rate of live births than placebo. Going on to question 7. So this is asking about the current approach regarding monitoring of TFTs in a patient who has undergone hemithyroidectomy but is euthyroid presently. So again, if you look at the ATA guidelines, women with overt and subclinical hypothyroidism or those at risk of hypothyroidism, for example, like our patient who has undergone hemithyroidectomy or is treated with radioiodine, they should be monitored with the serum TSH approximately every 4 weeks until mid-gestation and at least once near 30 weeks gestation. So that would be the correct approach. And this question is about the recommendation for levothyroxine dosing in a patient post-delivery. So the correct answer would be you reduce the levothyroxine dose to the pre-pregnancy dose and monitor 6 weeks postpartum. So again, this comes from the ATA recommendations that following delivery, levothyroxine should be reduced to the patient's preconception dose, and then testing should be performed at approximately 6 weeks. And this is about a treatment of an elderly woman who has subclinical hyperthyroidism. So the correct answer would be treatment with antithyroid drugs. So if you look at the recommendations for treatment of subclinical hyperthyroidism, so when TSH is persistently less than 0.1, like in the case that I showed, treatment is recommended in all individuals more than 65 years of age. So our patient was 68 years of age and treatment is definitely recommended. And if they are less than 65, it should be recommended in patients with cardiac risk factors, heart disease, or osteoporosis. And the reason for recommending treatment in all individuals more than 65 years of age is because subclinical hyperthyroidism carries a risk of atrial fibrillation and also osteoporosis. Hence, there is evidence for treatment for subclinical hyperthyroidism in this age group. So this question is about a 69-year-old woman who has an incomplete biochemical response to methimazole. She's planned for radioiodine therapy. She has a normal pulse rate. So you still start on beta blockers and stop methimazole 2 to 3 days prior to radioiodine therapy, because radioiodine therapy treatment of Graves' disease can cause a transient exacerbation of hyperthyroidism. Beta adrenergic blockade should be considered even in asymptomatic patients who are at an increased risk of complications due to worsening of hyperthyroidism, like for example, elderly. Our case was 69-year-old, hence indicated. And then there is also recommendation to stop the methimazole therapy prior to radioiodine therapy before 2 to 3 days of radioiodine therapy. So that is the end of this quiz. I stop here. I stop sharing. So do we go on to the answers for the practitioner's quiz, or should we look at the results now?
Yes, Lakshmi. If you can share the answers for the practitioner's quiz as well, it would be great. Yeah. Dr. Lakshmi, can you share the...
I'm just sharing.
Yeah.
Are you able to see the screen?
No, ma'am.
No, ma'am, no, ma'am.
Just a minute. I'm sorry, just give me a minute. Yeah. Are you able to see the screen now?
Yes, ma'am.
So these are the answers for the practitioner's quiz that we put out a few days ago. So the first question was what thyroid hormone abnormality is most commonly seen in patients with chronic kidney disease. And this is from a 2024 publication in Thyroid Research and Practice, which looked at the prevalence of thyroid dysfunction in patients with CKD. And low T3 was the most common at 58%, followed by low T4 in 23%, and overt hypothyroidism in 6.52%. So question number 2 is, in which situation is LT4 and LT3 combination therapy most beneficial? So is it in patients with cardiovascular disease or patients with persistent symptoms despite LT4 monotherapy, all patients with hypothyroidism, or patients with TSH more than 30? So the answer is patients with persistent symptoms. So this is again from a latest publication in Thyroid Research and Practice. So this is a very nice article which talks about the combination therapy rationale in the management of hypothyroidism, and it also gives some case scenarios where patients were started on T3 and what were their outcomes. So I found this very interesting. I encourage all of you to read this article. So this offers modest benefits in terms of symptom relief and quality of life compared to levothyroxine monotherapy. And this remains controversial, though, because of inconsistent evidence regarding its efficacy and concerns about long-term safety, potential cardiovascular risk, bone health, and fluctuations in thyroid hormone levels. So this question is about Bethesda system for thyroid cytopathology. It classifies nodules into how many categories? And this is 6. If you look at the categories, category 1 is non-diagnostic, category 2 is benign, category 2 is AUS, category 4 is follicular neoplasm, category 5 is suspicious for malignancy, and category 6 is malignant. And then the percentage, the percentage of malignancy that we see is also increasing as we go across these stages. So which of the following statements about thyroid nodules is true? This is a very easy question, and this is also very relevant for our day-to-day clinical practice. To know that the majority of thyroid nodules are actually benign, because most of our patients are worried and asking us continuously if all thyroid nodules require surgery. I think this is one very important point to remember in our day-to-day practice. So again, this is another very good article in Thyroid Research and Practice, which tells about the diagnosis and management of thyroid nodules. It gives a very simple algorithm to manage the thyroid nodules. If a patient presents to you with a thyroid nodule, how you go about it, and how you do the ultrasound, what you do, in a category of ultrasound, what you go on to do the FNAC. So this talks about the management of thyroid nodules, and most thyroid lesions are benign and asymptomatic. So this question is about the prevalence of subclinical hypothyroidism and type 2 diabetes, and the prevalence is around 10 to 15%. There are many studies with reporting different percentages, but when you look at a comprehensive meta-analysis, that it found that it was about 10 to 10.2%, and the prevalence in most countries is about 10 to 15%. So what is the most common cause of thyroid nodules in iodine sufficient areas? Again, banking on the last answer question, the answer to the last question, it's again benign. And smoking is a risk factor for many diseases, but less in subclinical hypothyroidism compared to the other risk factors mentioned here. Then, which of the following is a key benefit of thyromimetics? Question 8. So, do they stimulate overall thyroid function? Do they selectively target thyroid hormone receptors in the liver? Do they enhance cardiovascular activity, or do they primarily function as TSH suppressors? So the correct answer is they selectively target thyroid hormone receptors in the liver. And again, there is a very good narrative review on thyromimetics. Resmetirom is one of the the newly FDA approved drug. It's a liver selective thyromimetic. It has around 28 times higher selectivity for the thyroid receptor beta isoform, and this is a exciting new treatment modality in MASLD. And this article speaks about, gives us a very good overview on thyromimetics and their clinical applications. So which of the following findings suggests a high risk of malignancy? It's nuclear pseudo-inclusions. So nuclear pseudo-inclusions, although they are not specific, they are very common in papillary thyroid cancer, meningioma, and usual ductal hyperplasia of the breast. And they actually represent the invaginations of cytoplasm into the nucleus and are delimited by the nuclear membrane. So the last question is very easy. So which thyroid imaging classification system is used to assess the risk of malignancy based on ultrasound features? This is TIRADS. We spoke about it. So we have points on the ultrasound to risk stratify the nodules into TIRADS, and we give points to each of them based on the ultrasound features, and then we classify them from TIRADS 1 to TIRADS 5, and we have different FNA classifications for each of this, and also the risk of malignancy varies across each of this. So this brings me to the end of this presentation. I will stop sharing now. Thank you.
Thank you, Dr. Lakshmi, for conducting such an engaging and insightful quiz with such enthusiasm. I'm sure it must have been a valuable experience for all of the participants. I now request you to announce the winners of both the quiz. I request the tech team to display the winners of both the quiz. Dr. Lakshmi, I would request you to announce the winners.
So congratulations, winners of the quiz conducted for practitioners. Number 1 is Dr. Anjana Mohanan and Dr. Prabhuram TS. Congratulations.
Tech team, can you display the winners of the DM quiz as well?
Is it the one we see here?
Yes. Dr. Medha, yeah, you can announce Dr. Lakshmi.
So Dr. Medha Rao is the winner of the DM quiz. Congratulations to Dr. Medha Rao.
Dr. Amulya Reddy and Dr. Anne have stood in the second and the third place as well. So congratulations to Dr. Amulya and Dr. Anne as well. So thank you, Dr. Lakshmi, for such an engaging quiz. So we have now come to the end of the session. So I request Dr. Pramila ma'am and Dr. Arun sir to give the concluding remarks.
So thanks, Dr. Ganvi. And this was really a nice discussion today. We started off with a nice case discussion, and Dr. Ramya presented it, and well moderated by Dr. Arpan Dev, Dr. Abhilash, and Dr. Malika. And then we had a discussion on medullary thyroid cancer by Dr. Deepak, and then an excellent quiz by Dr. Lakshmi Nagendra, both for the practitioners as well as for the students, and lot of learning from that as well. And as we always tell, that we have our Journal of the Indian Thyroid Society, which is the Thyroid Research and Practice. And Dr. Lakshmi did show a lot of nice articles published in that journal. And I again tell all of you to please submit your articles to our journal, because this is the official journal of the Indian Thyroid Society. And kindly log into the journal and upload your articles if you have any articles on thyroid. So I also hand it over to Dr. Arun to give his remarks as well.
Thank you, Pramila. I'd like to thank the CME team. I think Pramila, Ganvi, Chitra, Vijay have really worked hard to keep this going on a regular basis. So thank you to the team once again, and thanks to the tech team as well. I don't want to waste more time thanking our speakers of this evening. Pramila has already said. So Arpan ji, Deepak ji, thank you so much for joining. Abhilash is of course a part of us in very many ways. Lakshmi has always been a supporter. And thank you, Dr. Mallika Danda ma'am, as well, for coming in this evening and giving a valuable insight. Thank you all once again. Over to you, Ganvi.
Yes, sir. Yes. Our next thyroid clinic session is scheduled for the April 9th, and we are eager to host you again. I thank one and all for being here and making this an engaging and informative discussion. Thank you all for joining, and we look forward to seeing you the next time. So those who are interested in Thank you all. Good night. Good night.
Thank you, ma'am.